The last presentation will be given by Carolina Malagelada. Again, an excellent Spanish or Catalan scientist with a well-known reputation in the field of gastrointestinal function. And she will inform us about the whole spectrum of the assessment of intestinal motility and transit, which technology provides the information we need. This includes breath tests, but goes far beyond that. Carolina, please go ahead.
I would like to thank the organizers of this symposium for inviting me to talk to you about the assessment of intestinal motility and transit, which technology provides the information we need. So small bowel motility disorders can be shown in this nice graph published a few years ago in Nature Reviews. It is a pyramid, and at the tip of this pyramid, we have those patients with most severe small bowel dysmotility. These are patients with pseudo-obstruction, and in them, radiology and symptoms are enough to diagnose these cases. They have small bowel air fluid levels or dilated bowels on a CT scan. At the bottom of this pyramid, we have functional GI disorders. In them, tests are generally normal, as you know, but motility is thought to be part of the pathophysiology of these disorders, and we diagnose them using symptom questionnaires. In the middle are the most difficult to diagnose patients. These patients are called enteric dysmotility patients, and in them, we need specific tests, motility tests, to diagnose them because they don't have the abnormal radiology that pseudo-obstruction have, but they are much more severe than the functional GI disorders. Enteric dysmotility, in fact, is quite prevalent. As you can see in this slide, these are the prevalence of pseudo-obstruction and enteric dysmotility in patients with small bowel dysmotility at 3 important referral centers from all over the world: Sweden, Italy, and the States. And as you can see, enteric dysmotility represented more than half of the cases of small bowel dysmotility detected or diagnosed at these centers during a period of 5 to 10 years. The problem is that enteric dysmotility patients cannot be diagnosed by their symptoms. Symptoms are very similar to pseudo-obstruction. This is a review of their series of patients from the Italian group. And as you can see, these patients have epigastric pain, early satiety, nausea, vomiting, fullness, distension, abdominal pain, the same as pseudo-obstruction, but also the same as patients with IBS, in whom severity may be a little less, but still have the same exact symptoms as these two other groups of patients with motility disorders. So when should we test, or what patients do we think may have a small bowel motility disorder? So patients with severe symptoms, those symptoms we mentioned in the slide before, but with signs of severity, and especially when they associate weight loss or malnutrition in the absence of a structural cause, of course. Also patients with systemic diseases, diabetes, collagen disorders, neurological diseases with digestive symptoms, in whom we think they may have a motor disorder. Also patients with subocclusive episodes in the absence of a mechanical cause, and patients with segmental motility disorders such as gastroparesis or colonic inertia, to determine if the small bowel is also involved, and especially before considering surgery in these patients, gastrectomy or colectomy. So are transit tests helpful to diagnose small bowel motility disorders? Well, these tests do have some advantages. They are widely available, And when they are abnormal, they may indicate a very severe motility disorder, and they may also show delay in a specific segment when we have morphology together with the transit test. Against these tests, there are some disadvantages. They are indirect tests. Normal range is very wide, and therefore they are only abnormal in severe cases, and we have the role of small intestinal bowel overgrowth, bacterial overgrowth, which we will mention in the next slide. So which tests do we have to measure transit? The most widely used test is the lactulose breath test. As you know, it involves ingesting an amount of lactulose, which travels through the stomach, and when arrives to the cecum, gives a peak in hydrogen in breath, and therefore we can measure the oral-cecal transit time. Normal values range between 1 hour and 3 hours, and it has been shown to correlate very well with scintigraphic transit time, but it does have some disadvantages. As we said before, it includes the gastric emptying time, which in patients with gastroparesis, which may be associated with a motility problem, may falsely delay small bowel or oral-cecal transit time. We also have an important interference in case there is small intestinal bacterial overgrowth. We may get an early peak in hydrogen, which falsely gives the impression of a short or normal transit time. And the fact that lactulose by itself has an osmotic effect, which may accelerate transit. Another test, which is not as widely available but may be very helpful to measure transit, is scintigraphy. So here on your left, you can see a picture of a normal small bowel scintigraphy at 6 hours, 360 minutes. Almost all, more than 75% of the marked meal should be in the cecum or the terminal ileum. And here on the right, you have a delayed case where, as you can see, at 6 hours, most of the meal is still in the small bowel. This test has the advantage that it allows separate measurement of the small bowel transit time. So in case we have gastroparesis, we can measure separately the amount of time in the small bowel. We don't have the interference of SIBO. And this test, since we have morphology, we can see specific delays in a segment of the small bowel, maybe suggesting obstruction at one point, a non-detected obstruction. Capsules may also be used to measure transit. We have the wireless motility capsule, and also the endoscopic capsule can be used to measure transit. But again, we have the problem of the enormously big, wide range of normal transit times. In this study, they measured transit time in patients of a wide range of ages, and as you can see, the capsule took between 1 hour and 6 hours to complete the small bowel. It does have the advantage that it allows separate measurement of small bowel transit time, so we don't have the problem with gastroparesis, we don't have the problem with SIBO, but this test is quite expensive compared to the other transit tests we mentioned before. So how can we measure small bowel motility directly? The gold standard test is intestinal manometry. Here in this slide, you can see a standard manometric catheter placed in the small bowel. We have 3 sensors in the antroduodenal region and 5 in the small bowel. And this is a normal recording during fasting. And you can see the MMC, the migrating motor complex, which occurs approximately every 100 minutes. And it is characterized by these strong contractions called phase 3, which occur, as I said, approximately every 100 minutes, and they move down the small bowel, moving all the residues of digestion into the colon. How can we relate the contractions detected by manometry and transit measured by transit tests? Well, in some cases, in some motility disorders, this is quite obvious. In this case, this is a myopathic small bowel motility disorder where motility patterns are normal, they are conserved. We have here a normal phase 3, but the amplitude of these contractions is very reduced. And as you can see here in the CT scan, there is retention of intestinal content and dilation of the small bowel. And in this case, obviously, transit time is clearly delayed. But in other types of small bowel motility disorders, such as this neuropathic case, you can see the small bowel is not dilated. It has a normal morphology, and the patterns that we see in manometry, which in this case, for example, are bursts of contractions, we do not know if this affects or not transit. So we do not know what a transit test would look like in a patient with this type of neuropathic small bowel motility disorder. So possibly the connection between transit and motility is going to be solved using this type of new high resolution manometry catheters. This is catheter, we've been using it in the last year in our lab, and it has 34 sensors placed in the small bowel, separated by 1 centimeter. And we obtain recordings that look like this. As you can see, we have 36 lines here instead of the 8 lines we had before. And if we place it next to a simulated version of conventional manometry by removing 30 of these sensors, we get this type of recording. So if we compare them, you can see that high resolution manometry allows us to detect contractions that propagate down the small bowel, which were virtually undetectable using the conventional catheter. If we have a look at this using the color plot, we obtain this type of images. And if we zoom in on phase 3, we see that phase 3, in fact, is composed of contractions that propagate very fast down an activated segment of the small bowel, which measures between 20 and 40 centimeters. And if you have a look at here at this picture, you can imagine this very fast contractions traveling down this segment and squeezing the small bowel and moving content rapidly down into the colon. Again, phase 2 before phase 3 also has propagated contractions, which were not detectable using conventional catheters. We are detecting these contractions approximately 8 per hour, and we expect these propagated contractions to have an important role in small bowel transit. A couple of abnormal examples. On your left, a normal phase 3. On your right, a phase 3 with abnormal propagation, which is interrupted. This would probably not be detectable or easily detectable using a conventional catheter. And here, an example of a postprandial period. Normally, the postprandial period has predominantly non-propagated contractions. And in this abnormal case, where contractions group into contractile events, which propagate very rapidly down the small bowel, and one would expect this to accelerate transit during the postprandial period. So in conclusion, transit tests are widely available and may be helpful to detect severe small bowel motility disorders. High-resolution manometry identifies propagated contractile patterns, which are not apparent with the conventional catheters. The role of propagated activity on small bowel motor function and transit of content remains to be determined. Thank you for your attention.